Ada orang luar. Okay, good morning, fellow and professor and all the urology resident, and good morning also for our distinguished professor from Binh Hospital, Ho Chi Minh City, Vietnam, Dr. Yu Dong Nguyen, my brother. I'm very grateful here on behalf of the urology residency training program. Today we have a urology webinar regarding to the hot topic about the bipolar enucleation of prostate. I would like to introduce our friend here. He is Dr. Dong Nguyen from Ho Chi Minh, and he is now doing some surgery in endourology, like in a supine PCNL and Holep and HERS, and now is also doing a bipolar enucleation of the prostate. He was joining some wonderful lecture, wonderful training in Torino with Dr. Cesar Sopon, and also go to Seoul with Professor Sung Yong Cho, as we know that he is now one of the maestro in endourology, and also join some course in Singapore. And also we are lucky here to host you in September 2017. I hope you can come back again, maybe in the future after the COVID recover. Okay, and as we know that our guideline now is more in Indonesia, following the European Association of Urology guideline, and for the prostate volume more than 80 milliliter, we have some first choice become a current standard of first choice of treatment from the open prostatectomy, and then Holep, and now is bipolar enucleation become the current standard or first choice, which is already supported by a good evidence level of some research. And that's why it's become very important for us now to know about this procedure, because this procedure, of course, have some advantages like cheaper, and because it's we don't have to have a lesser thulium or Holmium, which is in our country here. This is a very high cost procedure. So I think this bipolar enucleation can be one solution for us here to give the best alternative for our patient with a big prostate. Without further ado, I invite Dr. Dong to start the lecture. Dr. Dong, time is yours.
Yeah. Thank you, Indra. So I'm so honored to be a presentation for all of you in Sardjito Hospital about my topic is bipolar enucleation, the prostate. Actually, I have a great time in Yogyakarta in 2017 with Dr. Indrawarman. I went to the Sardjito Hospital and I took a picture in the front of the entrance of the Sardjito Hospital, and I had very fun time here with Dr. Indrawarman, with my friend Ahmed, and sorry, your brother, I forget, and then I had a great time in Yogyakarta. I hope I can come back to Yogyakarta after COVID-19 and to enjoy the time again in Yogyakarta.
Yeah.
So I think all of you will start to do the prostate treatment by the TURP. That means use resection the prostate, and all of you will know that when the bigger the prostate, the higher of the complication. As you see on this study, when the prostate become over 50 milliliters, the rate of the complication is higher. there's a lot of complication and such as confusion, TURP syndrome, UTI, even the failure of the treatment. And even you think that you can resection the prostate by TURP, actually you just reduce the prostate volume less than 50%. It's not incomplete procedure. And especially when you do TURP, all of you will know that the most difficult part of TURP is the area around the periodontum. I think it's very difficult for the beginner when started to do the TURP to resect areas around the periodontum. And many years, TURP is a gold standard of the treatment of the BPH. But when the technique and the time the TURP result is not good, it is not the standard because the result of TURP is based on a lot about the prostate shape. It is a middle lobe or not. Even the prostate volume, the higher volume, the lesser of the result it gets. And even when you do with the inflammation, the prostate, when you do from the top to down, you actually often the vascular lumen become bleeding and some absorbing the fluid to the body of the patient. And actually the TURP, even you are very good at TURP, it's not incomplete procedure. And that's why I think that the resection, that means you go from the lumen and go to the capsular. It's not the gold standard. It's not a standard anymore. It should be you go from the outer from the layer between the capsular and adenoma. You go inside. I think it's more standard treatment for the prostate BPH. And the next slide, I will convince you to change it from resection to enucleation. And the first enucleation process, actually from Dr. Hiroka from Japan in the 1987, and he is from Japan. He used the monopolar to enucleation the prostate, and some of his idea and device is still using today. But he is Asia and not up many doctors concerned about his study until now, until 1986. Dr. Peter Killing from New Zealand, he is a Caucasian. He do enucleation of prostate by Holmium laser with a high power Holmium laser and with the Moderator. And after his study, a lot of doctors concerned about enucleation the prostate. And today there's a lot of energy to enucleation the prostate. You have two groups. First is laser active enucleation. We have the Holmium laser, thulium yak laser, Rina laser, or the new laser is the thulium fiber laser. Otherwise, we have the second group. That means you use the electrosurgery to enucleation the prostate. I think it's cheaper and more available than laser. We have the monopolar, we have the bipolar device. So when we started to do enucleation, like me or like most of you, what should we energy you should choose? So as you know, today there's a very popular study about from Dr. Minh about enucleation is enucleation. That means he means that the energy is not important. The most important is the conception. And he creates the term, the hashtag aEEP. That means that he used the concept and enucleation the prostate is more important than the energy that he used. So I will explain to you about the hashtag aEEP. That means you're removing all the transitional zone. That means white, the yellow area. And from the outside to inside, that means you go follow the capsular, surgical capsular. Anatomic, that means that you go the right, follow the red line. It's not little, because if you go inside like this, it's an incomplete procedure. And if you go outside, it's a lot of bleeding and absorption the fluid. For more easier to understand, that means like you use the organs and you remove all the core of the organs and retain the capsule. And because of this hashtag aEEP from 2015, and with the two randomized controlled trials, comparison between the aEEP with the open surgery, and because of the result of two randomized controlled trial, aEEP, so enucleation of the prostate, by any kind of the energy goes inside to EU guidelines. Like Dr. Indrawarman say, most of us follow the EU guidelines to guide our treatment. And actually, like you do anything, the concept is just a first step to adapt a new technique. Day by day, you more involved, and you will know the difference between the types of energy. The concept is just the first step, and when you go master, you know that there's a little difference between each of the device and each of the energy that you use. That means like you go to the game, you go like the Mortal Kombat, you choosing between the Sub-Zero and Scorpion is little different. It's based on your skill, based on training. That's why from 2015 to 2021, there's another study about the comparison about the energy to enucleation the process. Even Dr. Herman also included into the authors of this study. But you see that the conclusion is that the bipolar enucleation is more efficacy, and the laser technique is more lower the risk of bleeding. So it's a little difference. And nowadays we are starting to do enucleation. We must know that each energy has a different interaction to the prostate tissue. And for choosing your energy, you must know the physics of the energy. You can know how to using it, and how the complication that it makes when you use it, and even how the financial, because sometimes in our area there's not full equipment, and I think that we work in the developing countries, and there's a lot of marketing campaigns to influence our thinking about energy. That's why you must be awareness about the commercial considered sometimes more than the science. And my choice when I started to do enucleation the process, I prefer to do with the bipolar, because I think that most of the residents is trained with the TURP with the bipolar device, and with the bipolar device I use the blunt dissection, so I easier to see that capsule. And of course, it's a cheap investment, because I think that all of the Vietnamese hospitals have available with the bipolar energy, and it is using the plasma and elastomers to the capsule and conception I will explain later. So I will show you the principle of the bipolar device. The bipolar device, that means that electric current doesn't go through the prostate, and we use the solution is different with the monopolar. Monopolar we use topical, and with the bipolar we use the natrium chloride, sodium chloride. So it lacks resistance to the prostate tissue, so all the current not go to the tissue, and that's why it makes your tissue less hitting. And because it's used with the sodium chloride, so it less the TURP syndrome. And for the plasmakinetics, it's created by the bipolar device. That means that there's a generator to have a spike energy to go around to the loop or receptoscope. That makes to the fluid around the receptoscope become to plasma. And with the plasma kinetics, it highlights the prostate. so there's no current go to the prostate. And you know that the plasma, the terminal effect of the plasma is just like a conducting. It's different with the monopolar. So the temperature when you touch in the loop with the parabola to the tissue is just around 30 to 40 degrees Celsius. It's different with the monopolar. And when we using the parabola device, when you press the cutting most, there sometimes there is a yellow light appear to the receptor. That means that it makes the activate the sodium ions and changing the sodium ion indication to the plasma. And my device to enucleation, this is the enucleation plate. I use this to enucleation. My device is to from the Olympus, but I have no conflict of interest with the Olympus. But I think that this kind of enucleation plate is a very convenient and very efficacy to enucleation because it has the two parts. The first part I use for blunt enucleation, and the second and the lower part I use for cutting and coagulation. I have some video clips after this PowerPoint to show you how I do it with this enucleation plan. And for the optimal enucleation, you must know the steps and you must know how to prevent the complication when you do enucleation. And the most complication when you do enucleation is sweat incontinence and oxygen incontinence, because you remove all the prostate. So sometimes the person will leak the urine after coughing or straining. When you do enucleation, that is very inconvenient for the patient and for a doctor. And sometimes because you do go, you will remove all the prostate. So sometimes it has the retrograde ejaculation when you after the enucleation. Even especially for the young patient, they are so very concerned about the ejaculation. So I will show you how to preventing the incontinence after enucleation. So this is the multiple centric evaluation about the factors for urinary incontinence after the enucleation the prostate. And the rate of urine incontinence is about 14.5 at 3 months, and it's less by the time. And there are some factors to make the patient get incontinent after enucleation. There is the patient age, the prolonged obstruction, even some metabolic disorder make the patient get incontinent. This is unavoidable factors. All of us can do is just use the technique to prevent it. If the patient gets a sweat incontinence after the enucleation, that means that he goes damage the external sphincter. And if the patient gets urgency incontinence, that means the patient urine a lot, and this urea, that means too much energy applied to the prostate cancer. And how to prevent the sweat incontinence, you must know the anatomic of the external sphincter. And if you see that in the picture, you see that the external sphincter is not it's a little different that we learned from the university. That means that the ventral part or anterior part of the external sphincter is higher level than the dorsal part. That means when you enucleation, you must concern about the ventral part or anterior part. It should be enucleation more higher, more close to the bladder neck than in the dorsal part to prevent to damage the external sphincter. And when you use the endoscopic landmass, you will see that when you go to the enucleation, you must know the border between the adenoma and the external sphincter. That is the wrinkle side or anatomic side. That means when you pull back your scope and you see that the wrinkle between the adenoma and the external sphincter. And for my technique, I also always do prevent the stress incontinence because it is a very inconvenient complication. By before enucleation, I release the attachment between the adenoma and the external sphincter, and I also always do less tension to the pancreas to preventing the stress incontinence. And for the urgency incontinence, it's another complication. The most reason for the incontinence after the surgery, that means that you apply too much energy to the cell capsule. That means you must, when you are coagulation, just white coagulation is enough, and that means that the temperature just around 60 to 70. You avoid to dark coagulation. That means you resting too much energy to apply to the cerebral capsule because it's no need, and it's helpless to coagulation. And I never use the white the rolling bone on the mushroom bottom for the coagulation. I always use the custom loop to the point coagulation for the bleeders when I enucleation. And to preventing the ejaculation for the young patients, because you know that when you enucleation on the prostate, you incidentally to damage the ejaculatory duct. That means the patient gets some complaint about no ejaculation when sexual intercourse. So to prevent it, when I started to enucleation, I always preserving the hood surround the vertebral canal approximately 1 centimeter. I never go enucleation very near the vertebral canal. And this is a study to comparison between the hood sparing technique and the non-hood sparing technique. With the hood sparing technique, the ejaculation preservation is about 15% of cases, and without the hood sparing technique, it's just about less than 30% of cases have the ejaculation preservation. And for the technique of enucleation, actually, when you read the study, there's a lot of the technique mentioned to enucleation the prostate. You have do the enucleation two lobe, one lobe, even the end lobe, and there's a lot of techniques to resolving the stress incontinence, like the posterior anterior or the V-shape. And nowadays, you heard about early apical releasing techniques to preventing the stress incontinence. So I will start it. I will show you my technique of the enucleation of the prostate. I prefer to do en bloc, that means no incision, no divide the prostate, because I think that with no divide the prostate, I will save in the time, because no need to divide the prostate, no need to try to do this. And with the en bloc, I have only one time to identify the capsule, so it's a very step in the time, and it's very inconvenient because I have one time to identify the capsule, and with this time I follow around the reference plan, and I enucleation the prostate. So I never had the chance of overlap when I'm doing the enucleation the prostate. And because when I do enucleation, when I do the en bloc, the space very confined because there's no water go inside to the bladder. So some irrigation is more clear than when you divide and open the bladder neck. I always doing preserving the paraverular region. That means I always to do the preserving the area around the vertebral canal, and I always do the early apical releasing. So I want to preventing the stress incontinence. This is the teacher from Professor Dr. Herman. He said that nowadays the trending the new trendy of the enucleation of the prostate, changing from the 3 to, and nowadays it's the trending go to the one lobe to or end lobe of the prostate. So the next slide, I will show you how I do it, the enucleation of the prostate. The prostate, that means that I make the demarcation between the external sphincter and the adenoma to preventing the stress incontinence. So I know I not go so below to the external sphincter, because if I go below the external sphincter, I will damage this sphincter and so and led to the stress incontinence. So I use the blade from Olympus with the two parts of the blade. The first is the upper part. I go for enucleation, and the second part is the metallic one. I go for the cutting or coagulation. So before I start the enucleation, I make the border between the adenoma and the sphincter. I put back my scope, and when I see that the green line, that means the border between the anal sphincter and the adenoma, and I use the lower part to demarcation. So I know when I enucleation, I know my border to preventing the risk of the stress incontinence. So I open back to see that the line. So after this, I will start to do the enucleation. And the first step I must go around the perineum, actually 1 centimeter above the perineum, because I want to preserving the ejaculation for the patient. So this is the video. You see that I use the lower part, the metallic part, to cutting. So I started to 1 centimeter up, above the perineum, because I want to preserving the ejaculation of for the patient. And so you see that I use the upper part to enucleation. This is the plum enucleation. You see that I use the upper part, the black one to enucleation. And when I see some bleeding, I use the lower part to coagulation. You see, I use my upper part to enucleate. And I go around the perineum. I just cutting to make it more losing, and then I use the upper part to enucleation. You see, it's very, with the blunt enucleation, I think it's easier to see the capsule. Sometimes it's bleeding, but I think it's easier way to see the capsule. So I go around the verumontanum. So you see that this is adenoma and this is also capsule. And this is the landmark. So the area around the veru is my landmark or my reference area to go around the verumontanum, to go around to the prostate. And after I enucleation around the verumontanum, I use this as a landmark or reference area to go to the lateral lobe. So, so I go around the lateral lobe because I have a right-handed right hand side, so I must go to the left first. And when I go to lateral lobe, if I feel some resistance, I pull back the scope and to find the marcation, the border between the sphincter and the adenoma that I did it before, and I resection it to make everything is smooth, smoother. This is this. Now I go back to enucleation. When I feel some resistance, I just pull back and cut into the line that I made before. And I go slowly to go to the 12 o'clock. I use the upper part, you see, upper part to enucleation. And when I see some details, I use the lower part, the mesolith one to coagulation. And with the same with the right side. Again, when I feel some resistance, I pull back my scope and I will touch in the area, you see, area attachment to the sphincter. And then I go back again and enucleation and just follow the circle capsule that I create around the verumontanum. And I slowly by both of the sides to go to the 12 o'clock. And every step, I must go very smoothly, not forceful. And when I go to the 12 o'clock, because I say to you, because of the external sphincter in the anterior part or the ventral part is a higher level than to the dorsal part or posterior part. So when I go to 12 o'clock, I must touch in a little bit higher level than in the dorsal part. So this is the ventral part. That is the flap attachment between the adenoma to the sphincter at the 12 o'clock. So when I go to the 12 o'clock, I just pull back the scope and I cut the ventral flap to make less damage to the external sphincter. So this is the next step. I go nearly to the 12 o'clock. And you see, I pull back, you see, to cut into the ventral flap. When I go to the 12 o'clock, I never go beyond the 12 o'clock. I just stop it at the 12 o'clock and cut in the ventral part, the ventral flap of the adenoma. And I do the same with the right side of the patient. I go to the 12 o'clock. Sometimes it's bleeding because it's a blunt dissection, and I cut in the ventral flap of the another side. And after I release all the attachment of the adenoma to the sphincter, now I start to pull up, to lift up on the adenoma to the bladder. You see, now I cut in all the attachment of adenoma of the prostate out of the anal sphincter. And now the risk of the stroke incontinence after surgery is very, very minimal. You see, all the anal sphincter is released out of the adenoma. And now I start to lift up on the adenoma towards to the bladder. Now it's on free, so I can lift it up and start to push it on the adenoma to the bladder neck. And when I want to enter to bladder neck, I always enter to the 12 o'clock because at this area the risk of the damage of the most of the ureter is very zero. So I always enter to the bladder neck, to the bladder at the 12 o'clock. When you enucleation, you know, you go very near to the bladder neck. When you see the longitudinal fiber like this, that means that you go very close to the bladder neck, and you must be very careful because the risk of the bleeding, there's a lot of vascular around the bladder neck. When I see the longitudinal capsule like this, I know that I very near the bladder neck. And of course, when you go near the bladder neck, there's a lot of bleeding, and you must coagulation it. And when I go to the bladder at the 12 o'clock by bladder dissection and very carefully to calculation on the vascular, and I push my stop to just stop to go to the bladder neck. And on this side, there's no risk of the orifice damage. And now after I go to enter the bladder neck, I go back to the 6 o'clock, and then I will push on the adenoma to the bladder neck. Now it's on free, and you can do it very smoothly because you release all the attachment. And you see that again, my movement to enucleation, I use the blunt enucleation with the upper part of my enucleation to enucleation, and the lower part to ejaculation and forecasting. You see that when enucleation, most of the part of adenoma is released. This is the final attachment. Now, this own attachment is resection or not enucleation. And this is the final look when do the envelope Holep for the 103 milliliter prostate. You see that this is variable tandem, and I always preserve area around variable tandem 1 centimeter above variable tandem. And when you look at all the adenoma, it is removing. And I don't think that you do any resection, you can remove the percentage of volume like this. It's all the area is of the adenoma is removing. And you see that I always do a calculation with the resection look. I never use the bottom or the mushroom. And in this case, my moderator is broken, and I must do the open cystectomy to remove the adenoma. And for my second message, I think that anatomic enucleation of the prostate is a complete procedure for the pediatric surgery. And with the plasmakinetics, I think that is the easiest way to start enucleation, because all of you training with the fibular for resection, and I think that fibular device is available for most of the hospitals in the developing countries. And for me, enucleation with the whole adenoma has a lot of advantages, because you have just in the time you never have the in the time, and a lot of advantages with the envelope enucleation. And you must use some techniques to preventing the stress incontinence, less energy applied to the capsule, and do the retro, and then do preserving the ejaculation for the young patient. And actually, when I starting something or you doing something new, the things aren't always what I assume, because sometimes you think that some surgery is easy, but actually from my experience, when I start to enucleation, I get a lot of complications, and even some cases which must be redo and all emergency situations. But I always do learning by myself, know it's my mistake, and the next case I involve a little bit, and day by day I involve my technique, involve my skill, and more make my surgery is less complication as much as possible. And thank you for your attention, and I'm very happy to discuss with you for my topic.
Okay, thank you, Dr. Dong. I give applause for Dr. Dong.